Hello, my name is Jessica Menifee. I am writing in regards to the stigma of opioid abuse and its effect on nursing care for the Nursing 360-201 Professional Communication in Nursing Practice. I chose this topic because of multiple reasons. The impact in society that it has today in terms of many things, some being financial costs, cost to individual families, cost to businesses, or impacts of healthcare, and barriers to care, and things that create a novel approach to care for this population of opioid use disorder as nurses, how it impacts our inpatient and outpatient care, and the stigma that we have created as a medical professional, a medical profession, as well as a community. The DEA estimates that the total economic burden of the opioid epidemic is $75.7 billion. That's about $41,000 per patient. That was written in the DEA docket 450. There's 11,000 people 12 years old and older that misuse prescription opioids every month. That was in the paper from Horner in 2019. And 73% of people label OUD as a physical, not mental condition compared to depression, schizophrenia, and alcohol use disorder. The impact that the stigmas that we have created on OUD preclude some of the treatments, the opportunities, the strategies of care that would best benefit these patients, this population. And as nurses, we are on the forefront of care for our patients all of the time. We come up with best practices that do such things as discuss alternative pain management strategies. And in the care of patients, there was a large community and educational healthcare setting in Massachusetts that wrote a paper stating that the stigma related to opioid addiction in healthcare creates many barriers to patient care, from decreased funding for supporting medicine programs in the community to ineffective care in the inpatient setting. They asked what some of these barriers they thought were for the nurses, and they then ranked these and tried to come up with alternative methods to help better these and give more resources to the staff as well as to the patients. The number one issue was the stigma that was created, again, by the professionals themselves, as well as by the patients, the families, the communities. Assessing and treating the pain is something that we fall short at on the nursing level as well as the provider level. But unfortunately, we find that there's a lot of burnout in both of those levels due to having to bridge that gap between patient, provider, community to make effective treatment plans for these patients. Nurses are to communicate between the providers, and when these barriers occur or when we're unable to meet some of the needs of the patient, then safety and security becomes an issue for the nursing staff, for the providers and ancillary staff, and ultimately for the patient themselves. I found that the most important question and the most important answer was, what did we think were opportunities for change? As a nursing profession, we often are good at identifying risky behaviors. We try to not downplay pain of our patients. We try to encourage avoiding harm reduction. Sometimes you will find that As a community, as a healthcare community, we do not enforce avoiding reduction services like needle exchange programs and things like that. So as a nursing population, we need to encourage and create those programs, make them more accessible to our patients, and be the bridge between the provider and the patient, and vice versa, to help to minimize these stigmas and potentiate their outcomes. Nurses incorporate standard evidence-based practices like educating on the self-needle exchange, basic wound care, overdose prevention. This is something that we do in our daily living, but this was also something that was noted in the Horner paper in 2019. Nursing is taking the initiative and their skill sets to turn the page on opioid abuse stigmas, but unfortunately we are still falling short due to the numbers that we read earlier. What I found in the literature related to the topic and barriers to care, as we listed above, I did kind of see some interventions that were being done. Barriers of effective OUD care in areas that create stigmas for this patient population are often a combination of patients, providers, the healthcare system, and insurance. Patient-level barriers include consciously and unconsciously applying societal stigma and people reporting pain, particularly if they do not respond readily to treatment. That was in the ANA brief of 2018. This leaves room for education to be steered by nurses in the community. Insurance coverage is very inconsistent and often limits comprehensive care for OUD patients, therefore stifling treatment and recovery of this population. Because best practice is pain prevention and treatment, particularly chronic pain, are continually evolving, and clinicians would benefit from continuing education related to the evidence-based practices. This is definitely something we are seeing in our annual web-based trainings, in our education that is necessary for our licensures, and this was found in the ANA brief of 2018. My intervention that I found to be the most impressive was the National Pain Strategy that was a combination of nursing and the DEA and several groups that helped, as the nurses are the front line and the liaison between patients and providers, to communicate the needs of patients with respect and dignity, as well as remaining an allegiance with the prescribing provider to create a team approach for comprehensive care of OUD patients. An interdisciplinary approach from medical systems is imperative to the patient's successful treatment and the assimilation into the community. Barriers are present within the system that create silos between departments and inhibit care by preventing the dissemination of information and education for the patient and the care team. This often opens the doors to assumptions and judgments of patients and their opioid use disorder, thus creating stigmas. We can change this culture of our respective healthcare systems to empower the patients, the providers, and the caregivers, and promote healthy relationships that cultivate a positive presentation of the patient and their cares. The interventions, again, were from a collective effort, and it represented identifying the at-risk population, providing them with social community, but ultimately outstanding medical care, intervening in a positive way for the patient, and rehumanizing the patient, giving them the power to regain some normalcy over their lives. And in this strategy, it outlined several ways that you can do that, from education, systemically and individually, from fine-tuning our education to the communities, especially the communities, not only those that are at risk, but those that are at risk of preventing care, to those folks, by not providing the funding that's needed, because they take those stigmas and turn them to dehumanizing the patient and their sense of being. Stigma associated with opioid use disorder and treatment affects a diverse group of patients, communities, caregivers, and can cause patients to forego life-saving medical services or withdraw from treatment. So if we are able to provide the education necessary, to provide the support necessary, to provide the reinforcements in the population of folks, there was about 73% of people felt, when you broke it down between middle class, working class, and upper class, the upper class had about a 16 to 18% increase in the stigma that they had towards opioid use disorder. And unfortunately, those folks are often your donors, your providers, your people of more influence to this population. So in providing that education, the reinforcement, the support, we hopefully will bring to the forefront the stigma and abolish that, to provide better treatment to our patients, to provide better treatment to our staff, to allow better quality of life for all of those involved, again, to potentiate positive outcomes.